Hello everyone, a warm welcome to the first of the series of 6 EBCA accredited webinars from ISCP A to Z CV Pharmacotherapy series. My name is Chan Ho. I'm an laboratory pharmacist at National Heart Centre Singapore. I'm the moderator for today. And today we have come to C, which is, we've come to F, which is Ferric Carboxymaltose, the use in heart failure treatment. All right. Alongside with me, I have Mr. Franco Cheng, a pharmacist at the University of Hong Kong, that will be co-moderating this session with me. And it's a pleasure that we are joined by fantastic faculty. We have Dr. David Sim, Deputy Head and Senior Consultant of the Department of Cardiology at National Heart Centre Singapore, where he's the Director of Heart Failure Program and the Clinical Trial Research Office. We also have Dr. Maurizio Volterrani, which is a Professor of Exercise Science and Medicine in San Raffaele Telematic University of Rome and Head of Cardiac Pulmonary Department at CCS San Raffaele. And lastly, we have Prof. Daniel Lighezan, Professor and Chief in Internal Medicine Clinic of the Victor Barbes University Medicine and Pharmacy at Timisoara and a board member of Romanian Society of Cardiology. Today's broadcast is supported by the International Society of Cardiovascular Pharmacotherapy, ISCP, and brought to you by Radcliffe Cardiology. This is thought to be an interactive session, which will feature a 10-minute live audience Q&A segment. So feel free to submit the questions to the faculty via the questions module with the web page, and we will endeavor to answer as much questions as we can towards the end of the broadcast as well. So before we start today's session, let's have a brief look at the agenda. All right, so sorry about that. So we would now like to hand over to Dr. David Sim, without further ado, to present on ferric carboxymaltose, ironing the issues and around heart failure-related readmissions. Dr. Sim, please.
Thank you, Chang Hong, for the kind introduction. So in the next 20 minutes or so, I'm going to present to you about ferric carboxymaltose. And basically today we are going to concentrate a bit more around heart failure-related readmission, how we can use iron therapy to reduce this heart failure readmission. So first, let's start off with iron deficiency. It is a very common comorbidity in heart failure. You can see, especially in the setting of acute heart failure, it's present in both chronic and acute heart failure, but especially in acute heart failure, the prevalence of iron deficiency is much more common than what we think it is. In fact, in some series, it has been reported to be as high as 70 to 80%. And even after admission for acute heart failure, 30 days after the initial insult of acute heart failure, up to 2/3 of patients still will have persistent iron deficiency. And what is the problem with iron deficiency? As you can see here, I think in terms of hemopoietic pathway, we all know that with a decrease in iron, it will result in anemia, and that will result in all the consequence of anemia. That I think we're all very clear. But there's also a non-hemopoietic pathway that results from iron deficiency. As you can see, iron is involved. It is essential for the normal functioning of the mitochondrial, and also there are non-mitochondrial energetic pathway as well. Is involved in oxygen storage as well. So all these things can go wrong in the setting of iron deficiency and potentially causing the patient with heart failure to have a worse outcome. And importantly to note that iron deficiency is not the same as anemia. A patient with iron deficiency will have a reduced quality of life, which is independent of the hemoglobin concentration in patient with heart failure. As you can see here, the iron deficiency is a much more powerful predictor of quality of life when compared to anemia. So it is not necessary to say that a patient needs to have anemia to have iron deficiency. It is possible to have iron deficiency despite the fact patient having a normal hemoglobin. And like what I said previously in the previous slide on quality of life, similarly, for the risk of hospitalization for heart failure, among the patient with heart failure, the iron deficiency independently increase the risk for heart failure hospitalization. And this is regardless of anemia. In fact, if you look at it, the group of patients who has the highest risk for readmission of heart failure are the group with iron deficiency together with anemia. And iron deficiency without anemia is actually a stronger predictor of heart failure hospitalization compared to those with anemia but no iron deficiency. So the key thing here is iron deficiency and not so much of anemia. And similarly, when it comes to mortality, we see the same pattern just like in the rehospitalization for heart failure. The iron deficiency is a much stronger predictor than the hemoglobin level for predicting who is going to have higher mortality among our heart failure patients. So we do have a few studies, looking at the impact of using intravenous iron, or more specific, looking at ferric carboxymaltose in the setting of chronic heart failure. For example, in the FAIR-HF study, the CONFIRM-HF, and the EFFECT-HF. But do take note, all these earlier trials, they were mainly done in the setting of chronic heart failure, where the patient are ambulatory in an outpatient setting, and these are ultimately treated patients with HFrEF, and they are class 2 to class 3 symptomatic patients with obviously iron deficiency. And when compared to placebo, the iron therapy or ferric carboxymaltose, they result in the primary endpoint, which is in all these trials looking at not hard clinical endpoint mortality or heart failure hospitalization, but mainly looking at symptoms such as NYHA class status, looking at patient global assessment, or 6-minute walk test. Essentially, all this study was positive. It showed that iron does improve the quality of life in terms of 6-minute walk test or improvement in New York Heart Association. But do bear in mind, this is in the setting of chronic heart failure. And what about oral iron? You may be asking, why not just use oral iron, when it comes in tablet form? It's so much easier to use compared with intravenous injection. But unfortunately, in the iron out heart failure study, where we use oral iron in the treatment of heart failure, there was a lack of efficacy. So among those patients with HFrEF and iron deficiency, high dose of oral iron did not improve exercise capacity over a follow-up period of 16 weeks. So this result do not actually support the use of oral iron in the setting of heart failure. In fact, we know that with oral iron, especially high dose, the patient tend to get a lot of GI side effect. So current guideline, whether it's from the ACC/AHA guideline or from ESC guideline, they do support the use of intravenous iron in patients with both iron deficiency and heart failure with reduced ejection fraction. So now let us come to meta-analysis of iron in patients who have HFrEF and iron deficiency. Yeah, previously stated out, FAIR-HF, CONFIRM-HF, all these studies done in an outpatient setting, unfortunately, they were very small study, only a few hundred patients each trial. So they were not powered to look at mortality and heart failure hospitalization. But when you combine all these trials and pull all the numbers together, there seems to be a suggestion that intravenous iron can have an impact on cardiovascular hospitalization and cardiovascular mortality. And there was also another group of patients that was not studied in the previous trial. There's a high-risk group of patients who are having acute heart failure. So the AFFIRM-AHF study was designed to enroll a high-risk heart failure population, those patients with acute decompensated heart failure. At the same time, the trial was also powered enough to look at the clinical endpoint cardiovascular mortality and heart failure rehospitalization, which was missing from the previous trial. So AFFIRM-AHF, for those of you who are interested, it is already published in 2020 in the Lancet. So the full publication is there in the Lancet, which you can access and read the details of the trial. So let me just go through on the AFFIRM-AHF some of the key points of the trial. So it is a trial for acute heart failure. The patient, in order to get into the trial, need to be admitted for acute heart failure. And after stabilization of the acute heart failure, they are randomized in the 1-to-1 fashion to get ferric carboxymaltose or getting placebo. And the total follow-up of the trial was up to 52 weeks or 1 year. So these are the primary and secondary outcomes that were interested in the AFFIRM-AHF trial. The primary endpoint was a composite of total heart failure hospitalization and cardiovascular death up to 52 weeks or a year. Secondary endpoint we're interested in is the cardiovascular death, total heart failure hospitalization, the time to the first heart failure hospitalization or cardiovascular death, and of course the composite of total cardiovascular hospitalization and cardiovascular death. And lastly, day loss due to heart failure hospitalization or cardiovascular death. Obviously, we are also interested in the safety profile and the adverse event as well. And these are some of the key inclusion and exclusion criteria. As I pointed out, patients need to be admitted for acute decompensated heart failure. Obviously, they need to have iron deficiency as well. So iron deficiency was defined just like the previous trial in the FAIR-HF and the CONFIRM-HF as a serum ferritin of less than 100 or a serum ferritin between 100 to 299 with a T-set value of less than 20%. And these patients who recruited are mainly patients who have REF with an ejection fraction of less than 50%. A small proportion of patients have a ejection fraction in the range of the mildly reduced ejection fraction. And exclusion criteria will include, a recent, CABG or recent stenting, within a short period of time, or any ACS or TIA or stroke within 30 days. And importantly, we also excluded patients, with a HB of less than 8 or a HB of more than 15, and anyone having active infection that required antibiotic, during the admission was also excluded from a trial. And obviously, anyone with recent intravenous iron or blood transfusion were also excluded from a trial. So this is the study regimen dosing regimen you can see here. So to make life easy, instead of using complicated formula to calculate the dosing regime, in this trial it was very simple. The amount of iron to be given throughout the trial was just based on the weight of the patient and the hemoglobin level. So that make it easy to use in the real world setting, right? So you can see that at week 0, the patient get either 1,000 milligram or 500, depending on the hemoglobin level. And at week number 6, they get a second dose of the intravenous iron, depending on their hemoglobin level and their weight as well. And lastly, only if the iron deficiency persists, they get another dose at week 12 or week 24. So technically, a patient in this 1 year of follow-up can get a maximum of 4 doses of the intravenous iron and a minimum dose of 1 dose. And this was the design of the trial. You can see that more than 1,500 patients were screened. Eventually, 1,132 patients was randomized, about 560 in each arm. And obviously, it was an intention to treat analysis. So as you can see, majority of patients, 80% of them, only needed 1 to 2 doses. All right, only 20% of them needed 3 to 4 doses. And there was an equal distribution, between the placebo as well, in terms of the number of doses that they received. So these are the pre-specified analyses. Because the trial was done during a period where we were impacted by COVID-19 that affect the, the follow-up of the patient, there was also a pre-specified pre-COVID-19 sensitivity analysis to look at the impact of COVID-19 on the clinical trial result. So these are the baseline characteristics of the patient. You can see it's an elderly patient, generally around 70 years old in both arms, the iron arm and the placebo arm. Majority of patients were male, slightly more than 50%, and systolic pressure about 120. Ejection fraction was about 32% in both groups. And class 3 to class 4 patients account for slightly more than half of the patient. Ischemic etiology, again, about 50% of patients. And about 1/3 of patients were newly diagnosed heart failure patients without previous history of heart failure. And all the comorbidities were listed there in terms of atrial fibrillation, diabetes, or CKD, very consistent with previous acute heart failure trial. And in terms of baseline pharmacotherapy, this was the therapy they were taking. You can see that ACE inhibitor about 50%, ARB about 17 to 18%, only a very small percentage was on ANI. MRA is about 2/3, and beta blocker, a high percentage of use of more than 80%, and more than 80% of them were on loop diuretics, because these are acute heart failure patients. And anti-BOPMP was more than 4,000 in both groups, higher than the chronic heart failure trial because this is setting an acute heart failure trial. Hemoglobin in general was about 12 in both groups. Anemia only present in about 50% of the patient because, as I previously mentioned, you do not need to have anemia in all patients with iron deficiency. Ferritin level in general was very low, less than 100 in both groups. And this was a primary endpoint. There was a trend towards a lower incidence of total heart failure hospitalization and cardiovascular death, but unfortunately, it just narrowly missed the p-value of 0.059. And if you look at the individual component of the primary endpoint, it was mainly driven by a reduction in total heart failure hospitalization. As you can see here, there was a 26% reduction in the total heart failure hospitalization in favor of those groups taking intravenous iron. In terms of cardiovascular mortality, there was no statistical significance between the two groups. And in terms of secondary endpoint of first heart failure hospitalization or cardiovascular death, again, there was a statistical significance mainly driven by the reduction in heart failure hospitalization. So if we were to factor into the impact of the COVID-19, because I remember when we were doing the trial in the year 2020, when COVID started hitting a lot of European countries, and here in Singapore, we had to find the trial as well. What happened was a lot of patients did not turn up for follow-up because of COVID-19. And as a result, if a patient don't turn up for follow-up, we can't, we can't, if a patient don't turn up, we can't clock the event that will affect the result of the trial. So if we were to factor in COVID-19 impact, you can see that the primary endpoint would have reached a statistical significance with a p-value of 0.024. But in terms of cardiovascular death, again, even if we factor in the COVID-19 impact, p-value is still not significant. There is this neutral effect on cardiovascular death. Mainly, it was a reduction in heart failure, total hospitalization, and first hospitalization. So in terms of the primary endpoint for pre-specified subgroup, you can see generally very safe to say that there's not much different that we can see, except we can see the hemoglobin level at baseline between less than 12 and those patients more than 12. It seems that those patients with hemoglobin of more than 12, there was an interaction that it seems to benefit those patients with a higher hemoglobin. Exact reasoning, we're not sure, but again, take with a pinch of salt because this, after all, just a subgroup so-called analysis. But generally, you look at the other parameters, whether it's heart failure etiology or the ejection fraction baseline, it generally, all the different group of patients do benefit from the use of intravenous iron. And in terms of safety profile, adverse event, you can see that really no concern here. We do not see any excess adverse event or serious adverse event in the group of patients taking intravenous iron compared to those group of patients taking placebo. And in terms of adverse event of interest, again, looking at it, whether it's infection, cardiac disorder, or GI side effect, we again do not see a very worrying sign that intravenous iron causes a lot of adverse event. All right, so generally very safe drug to use, which are not causing any problem even in a real world setting. One of the concerns with the use of intravenous iron is the drop in the serum phosphate level as a result of prolonged use of intravenous iron. But as you can see here, at the end of 52 weeks, we did not see any significant differences in the serum phosphate between the intravenous iron group and the group taking placebo. And in terms of ferritin, T-set in hemoglobin, again, you can see that in terms of the change of ferritin, the group at the end of 52 weeks had a higher ferritin level compared to those patients who were on placebo. And in the T-set, we also see a numerically higher value in the group who had a FCM compared to placebo. And the hemoglobin, we do not see a very much difference between the two groups. So in conclusion, in patients stabilized after initial episode of acute heart failure with concomitant iron deficiency, treatment with Ferric Carboxymaltose reduced the risk of total hospitalization. The p-value was 0.013. with no effect on the risk of cardiovascular death. All right. And if we do factor in the COVID-19 impact, this would have become statistically significant, the primary endpoint. And this group of patients who are high risk, the effect of FCM were not impacted by the anemia status. That is whether they're anemic or not, they still benefit from the drug. Right? And 80% of them only need 1 to 2 doses of intravenous iron during this 1 year follow-up. So most of the patients do not need frequent top-up of the intravenous iron. And importantly, safety profile was in favor of the drug. It was a very well-tolerated drug. So what is the implication for us, of affirmed AHF for our clinical practice? First, iron deficiency is something that is easily detected. All you need to do is a simple blood test with ferritin and looking at iron panel. And I think it should be accessed in patients hospitalized with acute heart failure. In fact, all patients, because it's something very common among acute heart failure patients and something that can be corrected easily. Important therapeutic target in outpatient heart failure. And administration of FCM in patient iron deficiency, ejection fraction less than or equal to 50%, who are stabilized after initial episode of acute decompensated heart failure, do reduce the risk for subsequent heart failure hospitalization. All right. Thank you very much. With that, I hand back to our moderator.
I thought it was quite interesting because this was a study that actually done in the pandemic, and then how they actually look at how we adjust for COVID-19 as well. Particularly when heart failure is always having such residual risk, it's important for us to minimize any risks for that, as just simply by 1 or 2 doses of IV iron. Perhaps now let's go through some of the cases first, and then we can raise some questions regarding be it FCM or iron therapy in general in heart failure. And meanwhile, so everyone, you can just put in your questions for us. We'll entertain it later as well, yeah? All right, so going through the cases, I'll go first with Mr. LG. He's a chef that's 60 years old. He was recently admitted for fluid overload, a symptomatic anemia from a PR bleed. So on examination, he has lung with bibasal crabs, pitting edema till below knee. He also reports a diarrhea of 4 days ago, and which the team is suspecting of possible gastroenteritis. So his latest echo was shown moderate mitral regurgitation, multi-R, with the LV function of 30 to 35 with severe left atrium dilation. So he does have a significant past medical history of AMI in 2003, which has been properly revascularized as well. He is on rivaroxaban because he has atrial fibrillation. And of course, the questions here we have is HFrEF. He is on all the top therapies that we have, the main 4 pillars of heart failure treatment. Apart from that, other medicines like rivaroxaban, which is currently held during admission because of his PRP. And of course, with atorvastatin, mecobalamin, and folic acid for his anemia. Then, on day 4, he's actually seen by the collateral team, which they scoped the patient. They noticed it's a congested internal hemorrhoids, which subsequently was resolved. And he also went through some successful diuresis with IV furosemide, and he achieved dry weight. So this is a laboratory investigation just prior to discharge, all right? And of course, the team has also decided on an IV iron, Ferric Carboxymaltose. So some questions that we have was, should he receive oral iron on discharge still? And when do we repeat another dose of IV iron? And how often should we monitor the HP apart from completing this FCM? Perhaps Dr. Sim, you can chime in on that.
This patient, he is admitted for acute decompensated heart failure needing intravenous diuretic. Based on his profile of hemoglobin 9.9, creatinine of 162, and transferrin saturation of 14%, he do qualify as a patient who will be a typical patient in the affirmed AHF study. So I think I will give him intravenous iron just before discharge, just as in the AFFIRM AHF study. And the question is, when should we recheck? I will probably just, follow what the AFFIRM AHF has done and maybe see him about 6 to 8 weeks time and repeat the iron panel again. If the iron panel is good, ferritin is now, back to normal, I will probably leave him alone. But if the 6 to 8 weeks time after the first dose of iron, there is still iron deficiency, then I will top up a second dose in the outpatient setting. I do know that there is a concern of, I saw your blood test result, a total white of 10 point something, just marginally up. So as long as he has no fever, the culture result all negative, no clinical evidence of sepsis, and he's not needing any antibiotic, I will be comfortable in giving him the intravenous iron before he gets discharged home. Because we know that patients with acute decompensated heart failure, the most vulnerable period is the first 30 days post-discharge, where they're very high risk of readmission and mortality. So, and the use of intravenous iron, I think here will be very helpful to reduce the risk of getting readmitted for the first 30 days, this vulnerable period.
Yeah, I do agree with Val. Would any of our other panelists have anything to chime in on this as well?
Well, actually, I completely agree with Professor Cheng, and we have to take care about the vulnerable period immediately after the discharge. And the best things to do is to set up a therapy in the patient that allowed him to stay safe and well controlled, actually. And I do believe that if we discharge the patient with the best therapy, that in this case means also to continue Ferric Carboxymaltose intravenous, we will do a great job and the best thing for the patient as well.
Okay,
yes, I agree.
If I could say also just a few words, it's perfectly normal what the case and the handling of the case was with Ferric Carboxymaltose in IV settings. I would like to state that the guidelines from 2021, the European guidelines as well as the American guidelines, which were released 2 weeks ago, stating also this kind of therapy, and we should not think about oral iron as a therapy. And 6 to 8 weeks to see the patient and to observe him, it's a very pertinent time.
Yes, I do understand that as well. If we were to do any times earlier, for example, if we were to recheck the iron within 4 weeks, probably the dose of FCM could also interfere with the SC of the iron as well. What do you guys think of his anemia? There's a probable cause to it, having PR bleed, maybe or may not because of the anticoagulants. Do you think that in this case, it's a gray area, be it whether it's a heart failure cause or with identifiable source of PR bleed? Do you think that in this case, is it still wise to continue with IV iron? Maybe
I think it's okay to continue with intravenous iron, but obviously if this gentleman has a PR bleed, I think the right thing has been done. He has been referred to a colorectal surgeon who did a colonoscopy and started treatment for the hemorrhoids and has stopped the bleeding. Obviously, we have to stop the bleeding. There's no point in replacing iron if we don't stop the source of so-called the iron loss. But I think in most heart failure patients, even without the bleeding pulse, I think he will probably also have the iron deficiency. In this case, I think it's probably multifactorial, not just from a pulse, probably from the poor ejection fraction or the comorbidity that also will predispose him to iron deficiency. So a lot of time we see in our heart failure patient, they actually don't have clear source of bleeding, In fact, most of them don't have bleeding, but yet when we test their iron panel, they do have iron deficiency. So I don't think the fact that he had PR bleed would so-called exclude him from having an intravenous iron.
Yes, I mean, I think Professor Singh is right. Just to complete the question of the intravenous, just to remind you that the iron out study that was as well done with a polysaccharide iron, but wasn't intravenous, wasn't on Peros. The problem, the result was neutral because the oral iron is not able to reach the level of ferritin or the saturation transferring that we need to have this kind of result. So the normal range, and it's very clear that this is the difference. So I think the iron, the intravenous iron should be the only one in this case.
Yes, I also think so too, Dr. Volterrani. I totally agree with that. So in this case, that probably you could say that iron therapy has certainly fallen in our favor if we are patients on heart failure as well. Maybe to Dr. Lighezan, could I check with you if the patient has improved EF? I mean, with all the standard therapy nowadays being so good and restoring heart function, if the patient's EF has improved, we are talking about improvement to up beyond 50%. Do you believe that he should still receive iron, IV iron as well in this case, if it's the same patient but with a different EF?
Okay, that's a very, very good question. As we know from the studies, the effect of IV iron was more in patients with less than 50%. If the patient has an ejection fraction over 50% and has no deposits of iron and has anemia, then we could give, but not for the EF as indication. If the anemia persists and it's anemia with deficit of iron, then we could use it as IV, but not for the indication of an ejection fraction over 50%.
I see.
So we actually have a question from the floor about the use of IV iron. We know that the topic of today is about FCM. Just wondering if maybe Dr. Sim can contribute a little bit more on that. If other IV iron therapy would be efficient for reduction of hospitalization or even in mortality as well.
Okay, so unfortunately in the setting of acute heart failure, we only have one trial to date. There's an affirmed AHF that the formulation they used was basically the Ferrinject or Ferric Carboxymaltose. So in the trial, it was just this iron formulation. We were not allowed to use any other iron formulation. And in the earlier trial, like the 5HF and confirmed HF, looking at chronic ambulatory heart failure patient, they were also using Ferric Carboxymaltose. So the bulk of the evidence come from the Ferric Carboxymaltose. And as a heart failure specialist, I do use Ferric Carboxymaltose, not just because of evidence in heart failure, but also because the earlier formulation, some of the earlier formulation iron, such as Venofer, they do have issue in terms of hypersensitivity to the iron. With the Ferric Carboxymaltose, the incidence of hypersensitivity to intravenous iron is very low. That's why we're very comfortable giving it in the outpatient setting as well, which we are doing now in the Singapore setting. So far in the patient that were given, a few thousand patients that were given in a hospital, where it's a quick 10 to 15 minute infusion, I don't think we have come across a single case of hypersensitivity to due date. So that is the reason why we still stick with Ferric Carboxymaltose. I'm quite sure in the future where more iron formulation come out and they are safe in terms of not causing hypersensitivity, I'm pretty sure it will work as well, because it's just about delivering iron to the patient. It's just an earlier formulation. We don't quite like it because of the side effect profile.
What about dosing? Because to me, back then I was working in the hospital and I always find it hard to calculate all this iron dose. You have to consider quite a lot of things because before you give it.
In terms of dosing, I think previously there are formula, Ganosi formula, all that, which is become a bit tough to use in the real world setting. I think for us here in Asia Pacific with our Asian patient, most of our patient, a dose of 500 for the smaller size patient, or a bigger dose of 1,000 milligram for the bigger dose, bigger weight, higher weight patient will do, you see. So usually I just base it on the hemoglobin, the starting hemoglobin, and the weight of the patient. That's why I refer to my previous slide in the Affirm AHF, where instead of using a formula in the trial, we just use two simple parameters that we can get in our patient. There's a hemoglobin level and the weight of the patient, and then based on that, we give either 500 or 1,000. So I will refer the audience to go back to the Lancet paper. It's all there, the hemoglobin cutoff and the weight, how we give 500 or 1,000. I find it much easier rather than doing a formula to calculate. Yeah,
thank you, Dr. Sim. An opinion from the panelists?
If I could ask, if I could add something about the sensibilization of the hypersensitivity reactions. We know that anaphylactic reactions after administering ferric carboxymaltose have been reported to occur with a rare frequency, less than 1 in 1,000 in clinical trials and also in post-marketing experience. Nevertheless, each patient should be observed for adverse effects for at least 30 minutes following each ferric carboxymaltose solution administration. And also, there is no evidence, or there is lack of evidence of pre-treatment with corticosteroids or antihistamines, and it is not recommended in patients with potential risk of hypersensitivity.
Thank you. So, any opinion from Volterrani?
Yeah. From the clinical point of view, I have to say again that I'm completely agree. Dr. Sim said, and not only for the reaction, the hypersensitivity or something like that. Even in our center, we use ferric carboxymaltose very, very often, and no one hypersensitivity reaction we have recorded. And again, also for the dosage, I mean, we usually do the same thing. So we started based on the hemoglobin with the dosage, and then we repeat 500 or 1,000, and then we repeat 10 days later after checking the ferritin transfer. And that's it. It's much easier than what we think, actually. You see very often and very rapidly the change in terms of functional capacity and in terms of quality of life, some symptoms actually in the patient.
Yeah, it seems that FCM do make our life easier. So maybe we can continue with case number 2. So case 2 would be a more chronic heart failure cases. This patient, no known drug allergy with a chair bound most of the time, hypertensive with diabetes. He also have an atrial fibrillation with LAAO done. The complete heart block is on ppm. The patient has benign prostate hypertrophy, and there was hypertension-related hemorrhagic stroke back in November 2021. The mid-leg lesion, the patient with on and off chest pain, not very serious, but do have some chest pain on and off. The coronal angiogram will took place in March 2022, which was just done actually. The patient has some gastritis and OGD back in 2021 as well, but otherwise it's normal. The left ventricle ejection fraction is about 35% in June last year. The clinic BB today is around 92 over 49 with a pulse of 60, and the home BP is quite low as well. The patient is now taking aspirin, pantoprazole for his heart condition, and the Sopolo, lisinopril, and spironolactone for his heart failure. Atorvastatin for the liver control. The patient is also taking multiple diabetes medication, dapagliflozin. I guess that's not only for diabetes, but for the heart failure as well. And also metformin, sitagliptin, pioglitazone. It's a little bit surprising to see patients still using the pioglitazone because of the known fluid retention side effects. The patient is also taking terazosin and finasteride for the DPH. Today he was admitted, there is several history of admission back in 2021, hospitalized 4 times unplanned, 2 for heart failure exacerbation requiring the use of dopamine, and 1 for dizziness, and 1 for post-BUD hematuria. So for this patient, the hemoglobin level is lowish all the time. And earlier this year, in January 2022, the iron is only 10 micromole per liter. The total iron binding capacity is 34 micromole per liter. B12 folate is otherwise normal, and the other lab value include the red cell, the hematocrit is lowish, but the anemia appears to be normal cystic, normal chromic. The HFR is relatively normal for this patient. So a few points to discuss right now. So should iron be given for patients with chronic heart failure? I know Dr. Sim has mentioned a lot about acute heart failure exacerbation, how IV FCM is beneficial in patients with acute exacerbation. But for patients with chronic heart failure, it seems that we did not talk a lot about that. Any opinion, Dr. Sim?
As well. That's because of the earlier trial of the FAIR-HF and the confirmed HF on this trial. And I previously said that in all the previous trial in chronic heart failure, when they did a meta-analysis, there seems to be a trend towards cardiovascular, mortality and reduction in heart failure admission. I think mainly is also driven by a reduction in admission, and that same result was replicated or repeated in the acute setting of AHF. So I would give in the chronic heart failure patient as well. In terms of would the use of all these iron increase quality of life, I've shown you in my presentation that they measure things like the 6-minute walk test, New York Heart Association, patient global assessment. They are all also so-called in favor of intravenous iron as well. So HFpEF, if up there, you put down there. I think this ongoing trial now looking at patients with a HFpEF. We shall await the result of HFpEF. Currently, the data is still mainly more for the HFrEF patient. And the last question you have up there for wheelchair or bed-bound patient, what's the role of SCM? I guess will be a bit controversial. If it's 84 years old who is already bed-bound, how much more do you want to give a patient? I think it depends on the healthcare system, how much you can support. I personally was still to give to somebody elderly who is wheelchair and bed-bound, mainly because iron is a relatively safe therapy and it's not a very expensive therapy, not like somebody that I'm going to put in an expensive device or not a drug that's going to cost a few $1,000s a month. It's a relatively cheap drug and easy to use, and one dose usually can last them 6 months. So to me, that seems to be quite cost effective. Yeah.
I see. What about Volterrani? Dr. Volterrani, do you have any opinion? Yeah.
Okay, we have to decide what we want for our patients. So, for example, the EMA, the regulatory agency, European regulatory agency, stated that the agency will not approve any other drug in the future that will not impact in a heart failure patient on functional capacity and quality of life. So that means that everything that I can use to improve these two pillars, I believe, in the life of our patient should be used, must be used, actually. And it doesn't matter if the patient is over 80, it depends on the biological situation. And so you have to try all the best to improve the life of your patient. It's not long life, but it's the quality life. And I believe that because iron impact with the energy in production in our body, this will affect not only hematopoietic situation, but also the other organs. So, for example, if you improve the possibility to work for your patient, I think you improve the best thing that the patient can do. Work in terms of exercise. So if the patient can move, is much more motivated and everything is better. And so I believe that we should follow the last key line, as Daniel said before, where before discharge the patient, you have to check the iron situation, and if the patient is iron deficiency, you must start with the therapy. The last thing is about the preserved ejection fraction patient. I believe that the result in the next trial that I think will come at the end of the next year will be more or less the same, will not affect the mortality, but will affect the quality of life. And this makes for me the big difference. Who cares about the mortality in this patient?
Thank you.
I think that in this case of our patient, which is chair-bound, like Professor Volterrani said, the quality of life is very important. I see it also from another clinical point, which we saw in all studies with IV iron, Ferric Carboxymaltose iron, which showed that the reduction of hospitalization is also very important for such patients. And it improves the quality of life and not to be so many times re-hospitalized. And for this patient especially, which is chair-bound, and we are trying to have a better quality of life for him, for using this kind of therapy means reducing hospitalization. And it's a very important point of view.
Yeah, exactly. I guess that's the reasons why the clinical trial is conducted. Just a little bit follow up on this patient, because we have some questions from the floor. Because back then in the AFFIRM-AF trial, it appears that patient with hemoglobin level of 12 grams per deciliter appears to benefit most. But for this patient, you can see that from the hemoglobin level, it hardly hits the 12 grams per deciliter. Would that be also a barrier or is a negative factor for starting this patient with IV iron? I know that was only a subgroup analysis, may not be very reflective to the entire population. But Dr. Sim, do you have any opinion on that?
I think, again, subgroup analysis to me always hypothesis generating. You still have to look at the totality of the trial. The patient with HP of less than 12, I will still give the intravenous iron for improvement of quality of life and reduction of heart failure hospitalization. I will not just base on the subgroup analysis and say that, okay, those patients with less than 12 hemoglobin, they are not going to benefit. I'm not going to give them, you see. So I definitely will still give and follow the trial inclusion criteria of between 8 to 15, the hemoglobin level.
I see. What about Wally? I think you also have some opinion on this issue, right?
If I can, again, I can say that, of course, iron is essential for in producing energy, either and it is involved in the metabolism of our body. But if you think from the clinical point of view, a patient with a 12 of hemoglobin is able to walk, for example, 350, 450 meters. So means that is already a patient that has, let's say, quite good functional capacity. And if you put in the same patient another bit of fuel, gasoline, of course, this will improve much more the situation. So it's probably a combined effect between the quite good level of hemoglobin together with a good level of ferritin or iron storage in the body.
Thank you. So I guess that is for our case presentation, but we do have some Q&A from the floor. Maybe we can start with the use of iron on clinical outcomes. So we talk a lot about the use of IV FCM for patients with acute heart failure. Just wondering, because Dr. Sim has mentioned there are some trials conducted. While using the PO iron, they did not improve exercise capacity. What about some clinical outcomes like mortality or hospitalization of heart failure? Dr. Lighezan, do you know if there is any study conducted so far to demonstrate if there is benefit or there is no benefit at all?
As far as I know, there is only one meta-analysis product a few years ago by Stephen Anker that put together Ferric F1, Ferric F2, and effect and so on, where he showed a reduction in mortality, but it's a meta-analysis. We don't have today any proof of impact, a positive impact on mortality in using iron, IV iron.
Yeah, let's continue with Dr. Lighezan. What about your view of using PO therapy? Then we'll go back to the case because I have questions from the floor about case number 2, but let's continue with the oral iron therapy first.
So regarding oral iron, you mean in clinical outcomes. I just can say that we just spoke that oral iron did not increase iron parameters. Hemoglobin nor had a favorable effect of any of the clinical parameters measured in heart failure patient. And the iron out study demonstrated that oral iron minimally depleted iron stores and did not improve exercise capacity. Moreover, the 2021 ESC guidelines states that oral iron therapy is not effective in iron depletion and did not improve exercise capacity in patients with heart failure with reduced ejection fraction and iron deficiency. So it is not recommended in this kind of patients.
Thank you. So I guess PO isn't the way out, although it's much simpler for the patient. Actually, we've got questions from the floor about the last case. That's because the audience thought that the patient is actually having TIA or stroke, and also with recent acute coronary syndrome. And these patients were actually excluded from the AFFIRM AHF trial. So would that be any particular concern when using iron in this group of patients, since these patients were not included in the trial? Dr. Sim, do you have any opinion?
I won't have. Well, in the real world setting, I will not have any reservation in using in a patient with with a recent TIA, because like what the other speaker has said, that panelists, that iron is needed for the energetics. It involves a lot of things. The normal functioning of the mitochondria. It's just that in clinical trial, we do exclude this group of patients. I guess because in clinical trial, we want to be more cautious and you want cleaner data. Yeah. But I would be comfortable giving the patient iron in this setting.
Yeah. I see.
Yeah. Agree. I completely agree. I think that if we think about the kind of patient that we have every day in the world, more or less 50% are ischemic patients. So we use a lot of iron IV, and also in this patient, no problem at all. And actually, we see the result actually very often.
Yeah, that's wonderful. Dr. Lighezan, any comments on the use of iron?
Yes, I fully agree with my predecessor speaker. It's the best, I think, for this patient, and this attitude is the best one for having most clinical impact.
So I guess time is almost up, but we have one question, right, Tom?
Yeah, maybe let's talk about infection risk. So what are our thoughts on, when we say that we can't give iron during active infection? What is your cutoff? Where do you stop at? Is it a mild fever? Is it a mild inflammatory marker elevation? Will you go on to give on the IV iron, or will you stop it? Because it's not just the iron that carries the risk. Even the intravenous access also carries a risk of infection as well. What are your thoughts? Maybe Dr. Volterrani?
Actually, we usually do not give iron in patient with fever, and also if there is some infective process as well, like pneumonia or something like that. But very often we notice, for example, PCR that is elevated without comorbidities or without clinical sign. And in this case, we don't care about the situation, and we use intravenous Ferric Carboxymaltose. But usually we don't use it when the patient is symptomatic or show some infection like pneumonia or something like that. And we wait until.
In our clinic, we are having the same experience. Parental iron must be used with caution, especially in acute or chronic infections. And it is recommended that the administration of IV should be stopped in patients with ongoing bacteremia. In patients with chronic infections, like Professor Volterrani said, a real benefit risk evaluation has to be performed, taking into account the suppression of erythropoiesis due to chronic infection.
Yeah.
I know time is running tight. Yep. Sorry, I know time is running tight, but we have an interesting question from Koji actually, because Dr. Sim have mentioned that iron deficiency appears to be more harmful than the anemia itself. Is there any direct mechanism that iron deficiency worsens heart failure but not passing through anemia? I think this is a very interesting question as well.
I think previously I mentioned in one of my slides all the disaster, all the adverse effect of the iron, because iron, as we know, it not just only affect the hemopoietic pathway. We know iron is involved in the erythropoiesis, but why do we see in some patients the iron store is low, but yet the hemoglobin is normal? Because there's the other aspect of iron, the non-hemopoietic effect of iron, which I show, where they have a impact on the mitochondrial and other non-mitochondrial energetic pathway, the oxygen so-called utilization, all that is it. And also, I think they also have the so-called some of these oxidative stress kind of stuff that iron is being involved in. So I think that's why, because of this non-poietic pathway, it's possible to find somebody with iron deficiency, and yet they do not always see a hemoglobin level that is low, to cause the so-called the poor outcome, for this patient iron deficiency. Yeah.
Thank you, Dr. Sum. I'm afraid that's all what we got time for today. So we have a lot of, still have some interesting questions that we cannot address. I'm sorry about that. I'd also like to remind all of you that today's proceedings will be shortly available on demand at the radcliffecardiology.com. So please go there to watch again. Before we go, we would like to, again, thank you our faculty today for their fantastic contribution. Dr. Sim, Dr. Volterrani, and also Dr. Lighezan. And finally, thanks to you, our audience, for joining us. We hope that you have found it insightful and to have met its objectives. Remember, this event is CME accredited. Please don't forget to submit your detail to claim your certificates. I guess that is for today. Thank you and goodbye.